I'm going to welcome Dr. Riaz Ahmad, who is going to present his first paper. He is from Peshawar and he is fellow in colorectal surgery.
Good afternoon. My name is Dr. Riaz Ahmad. I'm a fellow of colorectal surgery at Shaukat Khanum Hospital, Peshawar. I'm here to present the short-term outcomes of our laparoscopic colonic cancer surgery, which we performed during the last 1.5 years at our newly developed surgical setup. Anybody, please? Actually, I have to change the slides. So I have no conflict of interest to declare. Laparoscopy has been commonly used in the treatment of colon cancer surgery. However, it remains challenging to achieve the oncological outcomes equivalent to open surgery. Then, after a long debate and controversy, it is now well established and documented that laparoscopic colonic cancer surgery results in better short-term outcomes with improved survival. Despite its proven benefits, still laparoscopic colonic cancer surgery is underutilized among surgeons, and a steep learning curve is one of the main factors of its limited adoption. So the objective of our study is that whether laparoscopic colonic cancer surgery is safe at a newly set up, and whether a new laparoscopic unit can be established with comparable outcomes to the rest of the world. A brief about epidemiology. At present, worldwide, colon cancer is the second deadly and fourth most commonly diagnosed cancer in the world. Nearly 2 million new cases and around 1 million deaths they were recorded till 2020. And the incidence has been steadily rising worldwide, especially in the developing countries that are adopting the Western way of life. Obesity, red meat consumption, sedentary lifestyle, tobacco, alcohol, they are the main driving factors behind the growth of these tumors. However, due to recent advancement in the early screening and treatment option, the cancer-related mortality of this cancer, it has reduced in developed nation. In the next 20 years, China and USA, they will be having the highest estimated number of new cases. At present, colon cancer stands third in our country, following breast and lung cancer. Now, just like any other cancer, the earlier the diagnosis, the better the prognosis will be. Fortunately, colon cancer is a slowly growing tumor, and the benign polyp typically taking around 10 to 15 years to develop into a cancer. Though this cancer is increasing, but the potential for cure is known to increase when it is detected early. The overall 5-year prognosis is 64%. Excellent prognosis is seen if it is detected at a localized stage. The prognosis is 91% 5-year, and we see around 37% of the patient at this stage. If the cancer has spread to the surrounding tissues, the prognosis drops to 72%, and we see 36% of the patient at this stage. For distant metastasis, the prognosis is 14%, and we see around 22% of the patient at this stage. A slide about the brief treatment. Surgery is the only curative modality of localized resectable cancer. Currently, all the colonic cancer, they are treated with upfront surgery, whereas new adjuvant systemic therapy is not yet the standard. The UK Foxtrot trial of introducing preoperative chemotherapy is on long-term follow-up. In stage 3 patients, the adjuvant chemotherapy is the standard, and the use of adjuvant chemotherapy in patients with stage 2 disease, it is recommended only in patients with high-risk features for recurrence. And only the choice of palliation is left if the patient is having metastatic disease. This is our main objective, to determine the short-term clinical and oncological outcomes of laparoscopic colonic cancer surgery at a new setup. So we prospectively collected the data through our hospital information system, which is basically a prospectively maintained database from which we undertook this study. So all biopsy-proven colonic cancers of either gender above 18 years of age with acceptable ECOG for elective surgery between April 2021 to August 2022, they were included in the study. The data was maintained on hospital information system, as we are a paperless hospital, and then the data was analyzed through SPSS. Now coming to the results, a total of 68 patients underwent surgery. The median age was 42 with a range of 27 to 85. There was male predominance. We operate across the breadth in terms of BMI, though it's very difficult to operate on overweight and obese patients, but we do have operated on 17 overweight and 2 obese patients. All of the patients, they are preoperatively assessed by anesthesia team, and then they are given an ASA score. Majority of the patients, they were having an ASA 2, whereas 7 patients of ASA 3 and 1 of ASA 4 were operated to. This is the demographic of the patient which we received. Shaukat, Khanum, and Peshawar, they received majority of the patients from KPK and Afghanistan. 2 patients of Pindi and Islamabad region were operated to. This is basically the pre-operative staging. Majority of the patients, they present at T3 stage, while some are having T4 disease. On the other side is the lymph node stage. In Pakistan, because of the lack of primary health care, so our patients, they tend to present at a much higher stage, what the internationally published data is. The mean lymph node yield was 19. Majority of the patients they had R0 resection, whereas 2 patients had R1 resection. One had right hemicolectomy and the other had panproctocolectomy. Our length of stay was 5.8 days. Our mean operative time was 249 minutes. Mortality at 30 days was 1. And at our unit, we do follow the patient for up to 90 days in terms of mortality, and that we do include in our analysis. So the 90 days mortality was 2 in number. Now coming to the procedures that were performed, majority of the tumors, they were found on the right side of the colon. So the commonly performed procedure was right hemicolectomy followed by sigmoid colectomy. Extended right hemicolectomy was performed for the tumors in the proximal transverse colon and hepatic flexure. 3 patients had panproctocolectomy because they were having synchronous tumor in the rectum and ascending colon with multiple polyps throughout the colon. Now coming to a complication, as you can see, less frequent complications they are seen in our study. 5 patients have SSI, and this is because we do operate laparoscopically. 8 patients, they were shifted to ICU for less than 24 hours, and this is for the monitoring purposes of their comorbidities. 1 patient was converted to open, and this is purely because the patient was having locally advanced sigmoid colon cancer, and there was bleeding during splenic fracture mobilization. So we thought it will be good to to open the patient to control the bleed. 1 patient we have to re-explore during the same admission, and that patient had panproctocolectomy. On the first post-operative day, the patient developed pelvic hematoma, and we have to explore for the pelvic washout. About the mortality, if I go into the details, 1 patient had aspiration followed by respiratory failure, and the patient died after 3 weeks. The other patient went home, started chemotherapy, and then had chemotherapy-related mortality. But as that mortality was within 90 days, so we have included that in our study. Luckily, we have no anastomotic leak during the time period of our study, but unfortunately, we have seen 2 leaks in the last 2 months. This is the post-operative histology. As you can see, majority of the patient, again, they are having a T3 disease, which is consistent with our preoperative staging. And it also shows that our preoperative staging is fairly accurate. We not only operate on the early disease, As you can see in this picture, the small bowel is adherent to the locally advanced cecal cancer, and we have to go for right hemicolectomy with in-block resection of the small bowel. This is a picture of locally advanced transverse colon cancer involving the greater curvature of the stomach, and we have to go for extended right hemicolectomy with partial gastrectomy. So in conclusion, ladies and gentlemen, laparoscopic colon cancer surgery is performed at a high volume center by trained and experienced subspecialized surgeons, then is safe even in a newly established unit, and our short-term outcomes, they are consistent with those published in the literature. So in the end, I would like to thank my head of department, Sayyid Irfan Kabir, and my both supervisors, Dr. Muhammad Fahad Shah and Dr. Irfan Islam Nasir, for helping me out, for all the guidance, for advices. I'm grateful to them, and thank you.
Sir, for the question, any question regarding that?
I have a question.
Okay, sir.
Very nice presentation, and it's a very nice thing to see that new unit has been opened and you're doing good.
Sir.
I was surprised at one of your slides where it showed that you had the majority of your patients were right-sided tumors.
Yes, sir.
Now, we have quite a large volume of cancer in our unit.
Sir.
Up until 2019, the last COLOCON, that the conference that we held, we were doing 135 to 150 cases a year. So the summative total in that conference was some 8 to 850 patients, and it's quite a big volume. We are seeing more left-sided cancers now, and we hardly, out of 100, maybe 2 or 3 cases would be right-sided. I'm surprised that maybe in the upper part of the country, they still are having right-sided tumors. I don't know, Dr. Najib, would you agree that with my notion?
Yes, I do agree. The other thing is most of their tumors, they are also node negative. 35 or 38% are node negative.
Yes,
so
sir.
probably these are, have you done MSI studies on these stage 2 patients to see whether they are Lynch syndrome patients or not? Any idea?
Of course, sir, we do, like at Shaukat Khanum, we do operate on locally advanced, but majority of the tumors, they are early tumors. And as sir has said, that the upper part of country, like the Malakand and Swat and their division, we got majority of the tumors on the right side of the colon. And still, like even in the coming 2 weeks, we have to operate a few more colon cancers, which are involving the right side of the colon. So we are getting the right side more common as compared to the left side.
Assalamu alaikum. I would like to add further to what Dr. Riaz has said. So yes, so from the upper part of the country, we have got a lot more right-sided tumors as compared to the left-sided. But then again, it's a colon cancer, and normally the primary physician or the surgeon to whom they present initially, they don't leave actually right-sided tumors as well, as very rightly mentioned. So to whomever they present, they normally like to carry on with it. And the second part of the question, that MSI testing. So normally we offer MSI testing to all of our colon cancer patients, and according to the results, then the oncologists decide whether they would need further chemotherapy or not. Thank you.
Thank you.